Good afternoon, everybody. This is Dr. Jeff Gelblum coming to you from sunny South Florida, Miami to be precise. Today's discussion is really one of the most interesting experiences that I've had in over 20 years of clinical neurology practice. And what I'm going to share with you today are some of the exciting new advances that are available to all of us in the community clinical practice setting to determine if you or a loved one has Alzheimer's disease. Now, up until just about a year ago, if someone was having memory problems or difficulty of attention and focus, we would conceptualize of an Alzheimer condition, but we really never had the hard and fast diagnostic tools available to confirm the diagnosis. So what historically always happened is if you would bring your mom or a neighbor or a relative to me for Alzheimer's disease concerns, historically speaking, I would say, look, let's get an MRI to make sure it's not a stroke. Look, let's get an EEG to make sure that they're not having little seizures. Look, let's get some blood tests to make sure that it's not diabetes or blood pressure causing issues. Let's get some other tests to make sure that it's not a Parkinson's condition. But we never really had hard and fast diagnostic tools available to instantly confirm the diagnosis of Alzheimer's disease. Well, the good news is now we do. And that is the purpose of today's discussion, because historically, Alzheimer's, at least in neurology and in primary care, geriatric psychiatry, was almost like a diagnosis of exclusion, what we would call a wastebasket diagnosis, meaning we ruled out everything else and then, well, you're not suffering from all of that stuff, so voila, it must be Alzheimer's disease. And that's always rather unsettling, because it's always good to have confirmatory data when one is making that type of diagnosis, Alzheimer's, with all of its implications and its degeneration and then loss of independence and all of those things. But now we can make that diagnosis with certainty. So that's why I'm so happy to be on this conference call this afternoon, this Facebook Live, to share with you some of the new exciting, and this is not research, some of the new exciting, confirmed, approved diagnostic tools that we neurologists have available to us in order to confirm the diagnosis of dementia of the Alzheimer type. Now, as you know, as any of you who've participated on my conferences before, you know that there are multiple reasons for dementia. If you fall over in the street and get run over by a bus and it smashes your head, that's going to cause dementia. That's called traumatic brain injury. If you're walking in bad parts of town and you get shot in the head, well, that's also traumatic dementia, post-traumatic dementia. You have a stroke and you have difficulty with attention and focus following a stroke, well, that's called vascular dementia. Oftentimes, people with Parkinson's will get a Parkinson's dementia. If you've been infected with encephalitis from a mosquito, well, that's called encephalitic dementia or post-infectious dementia. If you have a chronic disease like horrible diabetes or uncontrolled hypertension or a wasting syndrome, well, that can be a metabolic dementia. So when we use the term dementia, that's a catch-all term. That's like saying cheese. Well, what kind of cheese? So it's very important for us in neurology and in general medicine to classify the type of dementia that someone has, because once it is appropriately classified and diagnosed, then we can come up with a treatment that will work. And the good news is now, in November 2021, we have FDA-approved treatment for mild dementia. So that's why I'm here today, to try and get the word out as soon as possible, as quickly as possible, to all of you to say, look, if you know someone who is having mild problems of memory, difficulty with some activities of daily living, like preparing a meal or getting lost when they're driving home, this could signal a dementia disorder, and then it's my job or the job of other neurologists to figure out if it's due to Alzheimer's disease. And that can easily be done without a lot of trouble. So we've really come a long way in the evaluation and management of a dementia disorder because we can really classify it. And once we know the type of dementia, then we can begin to treat. So the treatment is now available as well. That's an infusion on a monthly basis. Some of you have logged on previously. You know the name of that medication. It's called Aduhelm, A-D-U-H-E-L-M. It's made by the Biogen pharmaceutical company. It's a monthly infusion. And what it does is it takes away the beta amyloid plaques in the brain. That's thought to have the destruction of the brain tissue due to Alzheimer's. So how do we test for Alzheimer's? What are the things that I as a neurologist will do if you come to my office with your mom or yourself and you say, gee, Dr. Gelblum, I'm really concerned about Alzheimer's? Well, the first thing I'll do is, of course, take a history. I want to find out what it is you're not able to do that you could do. And it could be everything from problems with short-term memory to difficulty with visuospatial recognition, meaning sometimes getting disoriented or going into a meeting and not able to go through your agenda or the itinerary. And remember, the difference between dementia and simple forgetfulness is forgetfulness means, well, I forgot where I put my car keys. Dementia is, once I get the keys, I don't really know what they're for, or I'm having trouble using them. Dementia always implies some functional disturbance above and beyond the short-term memory loss. Because as we all get older, we all have some short-term memory problems. I'm always forgetting where I put my car keys. And I almost forgot about today's conference, but thank heaven I got the alert. And there it was, popped up, 12:30, here I am. And I'm sure some of you have forgotten about today's conference. And you'll have to watch this on our website as it's recapped. But dementia is more than just problems with short-term memory. Dementia implies that there's a functional decline. So first thing I do when I take a history is we do a mini mental status exam, which is a really quick little 30-point quiz to see how you're functioning. And then formal exam, obviously a neurological exam, looking in the eyes, checking the reflexes, coordination, finger to nose, all of that, just to make sure that you're not suffering from something like a stroke or Parkinson's disease, as could account for some memory problems. And then we do an MRI. Why? Because the MRI will let me see if there's another contributing cause. So the MRI is the first step in the dementia workup, aside from the history and the physical. I like to do a brain MRI just to see if there's a stroke or a tumor. There's a condition called hydrocephalus, which is buildup of fluid in the brain, and that can sometimes cause dementia. We basically put a little shunt in and fluid goes away and you're all back to normal. So remember, a lot of these things are extremely treatable. So that's why the earlier you can get into my office or the office of a close by neurologist, the better off you're going to be. So MRI first step. And once we get that MRI data back and we see that there's no evidence of a stroke or fluid pressure on the brain or a tumor or anything of that sort, then the next step is where we really get into the meat of the Alzheimer diagnosis. And there's two things that we can do to confirm the Alzheimer diagnosis when we suspect it. The first thing is something called a PET scan, positron emission tomography. PET scan is not taking Scooter the dog over to the vet and seeing how the puppy's doing. No, PET scan means you lie in a scanner, a little medication is injected into the vein, and then you lie in the scanner and then it lights up. And what the tracer, what the medication specifically looks for is what I mentioned before, amyloid plaque. Amyloid is like the schmutz. It's the dirt that gets onto the brain and it mucks up the communication between the nerve cells. So amyloid plaque, just like you have plaque on your teeth and the dentist has to take it off because otherwise your teeth can bleed and you get all sorts of gum decay. Well, amyloid, a different form, of course, than what you get in your mouth, but amyloid in the setting of an Alzheimer's, beta amyloid, to be specific, is considered to be one of the components of the Alzheimer plaque that causes brain cells to become injured. And that's considered to be one of the biomarkers. Beta amyloid is considered to be a biomarker, an indicator of Alzheimer's disease. And we now have a PET scan that I can send you for, where you go in, you get a little bit of a medication injected into the vein, and then we get back the result. And if we see those plaques light up, those beta amyloid plaques light up, then we know that you have basically a 95% likelihood of Alzheimer's disease. So that 95% is close enough as far as I'll go in medicine for confirmation. 95%, I'll take that to the bank all day long. Now, the problem is, in its weird and wacky way, Medicare and a lot of insurances don't cover for that Amavid PET scan, that specific type of PET scan. There's certain protocols that we can use to try and get that done outside of a Medicare scenario, but oftentimes there's resistance from insurance companies to pay for an expensive Amavid PET scan. Resistance from insurance companies to pay for something expensive? Earth-shattering. Wow, we've never heard that story before. But here in the U.S., we hear those stories all the time. I know that I have the benefit of having lots of visitors on these programs from Europe, France particular. You guys, the French have it figured out. Things are covered over there, and unlike we Americans, we don't have to scramble around to figure out how it's going to get paid for. But here in the good old US of A, certain things just aren't paid for. So therefore, the Amavid scan, which is a technology that's been around for several years, has the ability to identify an amyloid plaque in the brain with 95% sensitivity and specificity to that same degree. And with that positive finding, I can say, looks like you've got Alzheimer's disease. And I see Linda is participating, and she's saying the French are the best. Linda, I'll grant you the French are the best in a lot of things, but when it comes to things like a good old American steak or building a nuclear submarine, I think we have it on top of the French. But when it comes to medical care, I'll defer to French expertise and ability to get things done. But with that being said, sometimes the Amavid is paid for in the U.S. and sometimes it's not. And if it's not, then we say, what else do we have available to us that could possibly be diagnostic? Well, we have another tool available to us. And again, very sensitive, very specific, very easy to perform. It's called a spinal tap. So you say, oh my gosh, a spinal tap. That sounds like something out of Dr. Mengele. Well, let me tell you about a spinal tap. A spinal tap is basically a small needle is inserted into the base of the spine down here in the lumbar area. About a teaspoon of clear fluid is drawn out, okay? And we send that off to the lab. And we'll get a result back from the lab in about 3 days. And that lab will be significant for the Alzheimer beta amyloid marker. So for those of you that are needle averse and fearful of invasive procedures, as are most people, the Amavid scan is an option. But for those of you who may not want to pay for an expensive scan or don't have the resources to pay for that, we can easily do a spinal tap. Simple procedure, takes no more than an hour. It's done on an outpatient basis. You come to the office, you lie flat, we get the fluid, we send it to the lab, bingo, in 2 to 3 days, we get our laboratory result back, and we have the answer that we seek. So if the Amavid scan is positive, or if the spinal fluid exam is positive, and that specific spinal test is called an AB 4240, and Linda, no, it's not painful, so you have nothing to worry about. We numb it up with lots of lidocaine, and then we put a teeny tiny needle, draw off about a teaspoonful of that clear fluid that bathes the central nervous system, send it off to the lab, and you get your answer back in 3 days. So, Amavid scan is one option. Our spinal test, looking at this A beta amyloid 4240, is another diagnostic tool, but both of these extremely sensitive, extremely specific, and give us the confirmation that we need in order to say, here, bad news, good news. Bad news is it looks like Alzheimer's disease. Good news is that, thank heavens, you're in the early phases and we now have medication to treat. And I've discussed this with you on previous Facebook Lives, meaning the treatment that we have available is called Aduhelm. It's a monthly infusion, and it takes away the beta amyloid off of the plaque. And with that, the data show significant improvement in cognitive functioning. So for the first time ever, and I'm saying now November 21, 2021, I couldn't do this discussion 6 months ago, but I'm doing it today live because it's important to remember that these diagnostic tools are available to all of us in the neurology field, so that when you come to the office and say, gee, I'm having problems with short-term memory, or wow, mom is not the same this Thanksgiving like nobody had Thanksgiving last year. Yes, we did have it the year before. So this is really going to be the first Thanksgiving where we're getting together and we have the opportunity to see how everyone's doing. So that's why I wanted to get to you today, because if you're sitting at the Thanksgiving table and you look at the people there, and if they're older and you say, wow, they're not looking as good as they were in 2019, something's really off. And I would venture to say, at least at my table, if you like my turkey stuffing, something is definitely off with you. So if you're sitting at my table and you say this is the most delicious thing I've ever had, I think you might get that dementia workup, because my stuffing is just awful. My other things are good, but the stuffing, not good. So in the spirit of pre-Thanksgiving, looking forward to getting together, I want to remind you that if you see something with a loved one or a neighbor or a friend or a family member that looks a little off cognitively, memory-wise, if they say, well, this turkey's better than last year. Of course, there was no turkey last year. So if they suddenly say to you that this is the best Thanksgiving, better than last year, you almost have to think something may not be right. So that's why today's discussion is so important, because now that we're coming into the holiday season, and now that in many respects we're vaccinated and we're not so concerned about COVID infections being the death knell to us all, we're going to be going to holiday parties. We're going to be sitting at Thanksgiving tables. We're going to be going to Christmas parties, Hanukkah parties, New Year's Eve celebrations. And if you see, and this is, of course, observing someone before they've had a bottle of champagne or two bottles of gin, if you see something off where you're suspicious about a cognitive decline from your last observation, which would be 2019 in most respects, then I urge you to get that individual to medical attention, preferably neurologic attention, because the information that I'm actually sharing with you all today, in many respects, is not even known in the primary care setting, even though we neurologists work with this each and every day. So unfortunately, in my practice, by the time someone comes in for the evaluation, it's often too late, because as I've told you before previously, these new medications that are FDA-approved are really for mild Alzheimer's. And we know that patients will only stay in the mild phase for 2 years. So if it's been 2 years since you've seen Aunt Esther and she's looking a lot worse, time is really of the essence. Or if the family says, wow, over the past year, Grandpa Joe has really gone downhill cognitively, then at that point, it's really important to get that patient to medical attention, to neurological attention. And for any of you who are concerned, maybe living far away, we've got this great website, this great telechat platform called Neuro2Go, Neuro, number 2, go, like you've heard of Uber to go. This is Neuro2Go, only it's not run by Uber or Amazon. Neuro2Go.com is a great resource where you can log on, schedule a chat with someone like myself or one of my colleagues here at First Choice Neurology, because we've got over 100 neurologists, so we're all happy to chat with you about this situation in English, Spanish, Francais, whatever you want. I think even Russian. We can have a discussion about whether there needs to be a concern about mild Alzheimer's. We've got the diagnostic tools to confirm, and we've got the medication to treat. This conversation could not have occurred 6 months ago, and it certainly couldn't have occurred in 2019 Thanksgiving. So as you're sitting around the table on Thanksgiving, and you ask Uncle Sam to carve the turkey, and he looks somewhat quizzical, that's the tip-off that we may be dealing with a Alzheimer dementia disorder. So I urge you all, since we're all coming into a great holiday season where the world has reopened and we're all going to be together, keep an eye out for older loved ones who are starting to show signs of dementia, meaning forgetfulness and some type of functional impairment. Remember, we don't use the term senility anymore because that's not a diagnosis. Senility just means old. Senescent, sene, in Latin just means aged. So just because you're old doesn't mean that you get dementia. I mean, my grandfather, on his deathbed, remembered that I owed him money and he had to collect before he died. So just because you're old doesn't mean that you're entitled to be demented. So therefore, I think it's extremely important that you recognize that dementia in its mild phases is diagnosable and extremely treatable. And if you have questions about yourself or a loved one and can't make it to the doctor for a formal appointment, go on nerdigo.com. The website information is displayed below you. And make sure you get into the hands of a neurologist, because nowadays, with the MRI, with the PET scan, with the CSF, spinal fluid eval, we're even coming up with blood tests that are pretty soon going to be commercially available. Time is of the essence. You've got 2 years in the mild phase before it's difficult to treat, but within mild, we can now treat. So that's why I'm very proud to bring you this information today to share with you where the technology is that didn't exist about a year ago. So this is cutting-edge information where we are now in an era, in an environment where Alzheimer's is treatable. We can actually modify the disease. So that is why I am here today. I look forward to chatting with any of you on the Neuro2Go platform. I'm available to do that, as are my other colleagues in First Choice Neurology. And anything that we can do to help confirm the diagnosis, clear up the questions that you have, and make sure that patients are successfully treated and effectively treated, that's where we want to be. So I thank you for your attention today. I'm sure you've got other questions. That's what neuro2go.com is for. And if there's anything that we can do in our neurology practice to help clarify and effect a journey in a dementia setting, that's why we're in business. That is what our mission statement is all about, to treat you as effectively and quickly as possible. So I appreciate your attention today, and I look forward to meeting with you again during the holiday season, where we'll come up with another neurology topic. And please text us whatever you'd like discussed, and happy to oblige. All right, everyone, I wish you a great Thanksgiving. Don't eat my stuffing because it's not that good, but my barbecue turkey is really excellent. So that'll be something worth trying. And looking forward to a wonderful holiday season, and happy to be here and to be of service. Have a great afternoon.